Welcome back to our next series of Doctors for a Cause Masterclass. This is the Neurology Masterclass by Dr. Tirthankar Guha Thakurta. I am Devashish Agarwal, a final year medical student from KPC Medical College and Hospital and a core member of Doctors for a Cause. Doctors for a Cause is a non-government, non-profit organization. We are a body of medical students, interns, and young doctors based primarily out of We are working days at a time. We seek to spread awareness, education, and goodwill. I would like to take this opportunity to thank all our followers and our well-wishers for all the love and the amazing response for the donation of the Amphan Relief Drive. Dr. Tirthankar Guha Thakurta is an MD Physiology and a teaching faculty at KPC Medical College and Hospital. DFC would like to thank Sir for an amazing session on ECG. That is our ECG masterclass. The video is up on our YouTube channel. You can always go back and watch it live. As we move into this new series of DFC of Neurology masterclass, I hope all of our doubts and confusions are cleared after the class. I would like to mention that all your questions are welcome, and Sir will surely try to cater to them as soon as possible. For the same, the chat box is always open, so you can always send in your doubts. The microphones of all the participants have been purposely muted by us for the smooth running of the class. There are some sets of protocols that we usually follow in these classes. Like if Sir is asking any question, send in a Y for yes and N for no. So let us now begin with the Neurology Masterclass. We welcome you, Sir. I would request you to take over.
Thank you, Devashish. Am I audible?
Yes, sir, you are audible.
Okay. So, I welcome all of you to this class. And in today's class on neurology, let us first discuss what is the approach we will follow in this 4-day session. Neurology cannot be mastered in 4 days. That is the honest confession. No subject can be, probably. But what we will try to give you in these 4 classes is a general insight of common explanations to the doubts that we face in the words, the physiological and anatomical basis of the clinical practice of neurology, and then the actual clinical examination and a rational approach to diagnosis of sensory or motor weakness in clinical words. So we have organized the neurology sessions in 4 parts for your convenience. When you go to the wards and you examine patients for neurological disorders, it starts with a protocol of examination. So in the first class, we decode that protocol in very simple terms, in explanations based on neuroanatomy and neurophysiology. So simply speaking, in our first class, we will be essentially explaining why certain things are done, how certain things are done, what it means to get a positive finding, what it means to get a negative finding. And for every what and why that we ask in the word, there is an explanation. We'll try to get as close to the explanation as possible. So the first class is essentially a recapitulation of the basic subjects based on the clinical approach. In the second class, we will discuss how do we localize lesion in the brain or in the spinal cord or in the peripheral nerve when a patient comes with a neurological complaint. This in neurology is known as localizing sign. Neurology differs from other streams of medicine in one particular way. If you see, in most medical facilities, we are more interested in the etiology of the disease than on the location. Say, for example, if you have an abscess, that is an infection causing pus-filled cavity, more important than where the abscess is important why the abscess happened. Because your choice of antibiotic depends on the etiopathogenesis, not on the location always. In contrary to this popular way of looking at etiological model of disease, neurology varies in one way. Because nerve damages most often are irreversible, so the extent of damage, the prognosis of the disease depends very much not on how the disease happened, but more on where the disease happened. For example, there may be ischemia causing nerve injury, but whether the damage is ischemic or hemorrhagic, it is more important to ask the question that is the damage at the level of the internal capsule? Is it at the level of the left parietal cortex? Is it at the level of the thoracic segment of the spinal cord? Because on that depends the prognosis, clinical feature and manifestations of the disease. So this is in one way that the approach to neurology is more anatomical and then etiopathological, unlike other diseases where it is first etiopathological and then anatomical in nature. Now, for this reason, we must have a very strong foothold on localizing signs. We have to understand where the disease has happened. And this we will discuss in the second day of the class. We will try to combine today's discussion in formats of clinical examination and try to find out how by simple bedside examination, even without the help of a MRI scan strip, we can understand and very fairly locate where the neurological deficit lies. In the third discussion session on neurology, we will discuss two distinct but very closely related areas of neurology, the cerebellum and the basal ganglia, because their presentations are slightly different. Whereas most neurological deficits will present as weakness or paralysis, basal ganglia and cerebellar diseases do not cause paralysis. They will present as a difficulty in planning, execution, and coordination. So they have been kept as a separate discussion. And on the fourth day, we bring together all these facets and we study the approach to a patient with hemiplegia, a patient with paraplegia, and a patient with various kinds of neuropathy. So the clinical approach will be discussed based on the 3 days discussion. So I think the approach is clear to all of you, and this is the approach we are going to follow. So in our first class, we are going to discuss about how different phenomena in neurology, different findings in neurology can be explained. So we start with the format of a neurological examination. I think the PowerPoint slide is visible to all of you. Please write Y if you can see it, then I'll be sure that you can see it and I'll proceed. Okay, thank you. So in neurology, when you start doing a neurological examination, we usually follow certain steps. Now, when you follow certain steps, your aim is to scan the whole nervous system and come to a conclusion as to how the nervous system of the patient is functioning. So before we go into this format, let us quickly discuss how conventionally we classify nervous system. This is very elementary and most of these have been learned in elementary school only. We know that we commonly classify nervous system into central nervous system and peripheral nervous system. Central nervous system includes brain and spinal cord, and peripheral nervous system are the cranial and the spinal nerves. They are organized into motor nerves and sensory nerves. The motor nerves can be voluntary neurons, neurons mediating voluntary activity, and they comprise the somatic nervous system. They innervate the skeletal muscles. And then we have the autonomic nervous system. They are controlling the activity of the smooth and the cardiac muscle and the activity of the glands. They are again further divided into sympathetic and parasympathetic division, and a third division has been suggested as the enteric nervous system. And the sensory system carries all the impulses towards the CNS. Now in this connection, it is actually very important to understand that the sensory system has both a central and a peripheral component, and they are related. In a similar manner, the motor system has a central component and a peripheral component, and so they are related. So it is not that the motor system is a part of peripheral nervous system only. The planning, execution, coordination occurs in the CNS. And the peripheral execution, that is the actual muscle contraction, happens in the periphery. So with an idea of what components constitute the nervous system, let us now see how we simplify and conventionally examine a patient with a suspected neurological disorder. We usually do a detailed history taking, followed by a general examination or general survey, and then that is followed by the nervous system examination. Now, to remember the nervous system examination, sometimes we use this mnemonic PSSC MRCS GT. Now, if I go one by one, they stand for, P stands for psyche or the higher functions. So when we say psyche or the higher function, it refers to all the intellectual functions of the brain. So functions like memory, functions like learning, attention, concentration, orientation to time, place, and person, cognition, conation, emotional expressions, all these things together constitute the psyche. So if you really have to study the P component, that is psyche or higher function, you have to do something which we call a mental status examination. That is a very detailed examination. If time permits, I will try to discuss it on the fourth day because it involves a lot of psychiatric terminologies. For simplicity, today I will discuss a few nuggets of what is the bare minimum that we can test at the bedside, even without a very detailed idea of psychiatry. The next S stands for speech. So you examine the speech of the patient, and sometimes you don't have to do a special examination for this. While you are obtaining the patient's history, if the patient can speak, then while recording the history only, you can actually assess the speech. So it does not have to be done separately. And I will also explain what are the components of a speech and how do we assess whether the speech is normal. Then you assess from outside the appearance of the spine and cranium. So is there any deformity? Is there any obvious swelling? Is there any abrupt angulation of the spine? Is there any tender spot over the spine and cranium? These are the things that we see under spine and cranium. Again, this examination overlaps a little bit with examination of the spine in orthopedics. Then we sequentially study all the cranial nerves from cranial nerve 1 to cranial nerve 12. Then we examine the motor system. Reflexes are part of both motor and sensory system. They can be tested with any one system. They are mentioned separately so that we don't forget about it. Then we look for autonomic function under control of bladder and bowel. Now, autonomic function includes many other things like regulation of the heart rate, respiration, regulation of the blood pressure. But you can see that many of them are already covered under general examination or general survey. So separately, we examine the control of bladder and bowel to get an idea of the spinal autonomic activity. Then comes the sensory system examination. So here you look for different sensory modalities, the pain, touch, temperature, then you look for cortical sensations, you look for vibration and proprioception. Spatial senses are already covered under cranial nerves, so they don't have to be separately tested. Then you look at the patient and see how the patient is walking, because sometimes that can give a lot of information. And this is known as gait. The walking style of the patient is gait. Again, this definitely overlaps with the motor system examination. It is mentioned separately because it is a very common point that we forget to test. So if it is written separately, at least you will remember that you have to test this. Then comes trophic changes, that is the nutritional status of the muscles. You can do that under motor system only, or you can also test that separately under a separate heading. So this is a basic protocol of examination of the nervous system. And out of these, today we will be discussing the anatomical and physiological basis of some of the selected examinations, and then discuss in detail why certain findings are found in certain neurological conditions. So I will not start with psyche or higher function because that is a more difficult topic to start with. I will only talk about the bare minimum that you do at the bedside. So at the bedside, you can ask the patient whether the patient is oriented to time, place, and person. This can be simply done by asking the patient, where are you now? Can you, if the patient says, I'm in a hospital, you can ask, can you name the hospital? Can you name the city where you are in? Then you can ask about the time. What time of the day is this? More precisely, can you guess the time of the day? You can ask about a known person, a familiar person in front of the person, saying, who is this person to you? That person may be a son or a daughter or a spouse. You can also look for a memory of certain common items. You can test the knowledge of proper nouns and common nouns also. So you can ask the name of the person standing beside if the person was already known. You can also ask the name of common objects like a fruit, like a pen, and see whether the person can recognize the objects. Also, ask about the long-term memories. The easiest way to test long-term memory is to ask things that are very old in the sequence of the lifespan. Like you can ask, in which school did you study? Where did you grow up? What is the address to your house? What is your father's name? Short-term memory can be asked by giving the person a few cues. Like you can mention to the person that I am mentioning the three names of three objects. You listen very carefully. So you mention three unrelated things like an orange, a dog, a pen, and then ask the person to repeat. Once the person repeats, it is a recall function. You know that it has been recalled properly, and also it has been registered. That is, there is no hearing disability, there is no speech disability. And then you start engaging in a different kind of conversation. You do other tests then. Ask about the time, place, person, etc. Then after spending some time, get back and say, do you remember the name of the three objects that I told you? Now, if the person can recall that, that is a short-term recall function. So you can also test numerical abilities. Numerical abilities can be tested in this way. You can say that suppose you went to the market carrying 20 rupees. Now, if you buy an item using 3 rupees, how much is left with you? Then the person says 17. Then you say you buy one more of that item. How much is left with you? And in this way, you go on. And this is known as a sequential subtraction of 3 tests. A similar thing can be done for people who are more formally educated. So you can also do a sequential subtraction of 7 from 100. That can also be done. Recollection of number can be tested. You can give a random number, which can be your mobile phone number, and ask the person to remember. Usually we can recall at least 5 digits forward. And if you ask the person to repeat backwards, usually the person should be at least able to say 3 digits correctly backward. So in this way, the mental status examination can be in many ways tested. This is only a few basic tests that we do at the bedside, and more detailed tests can be done under a formal mental status examination. I will now focus more on speech. So when a patient comes to you, what is your approach to a patient whose speech has to be understood? So under speech, what are the points that we will commonly examine? After discussing this, we will come into physiological explanation for the same. When you discuss about speech, you understand the volume of the speech, the articulation or pronunciation, and finally the content. That is, what is the person speaking about? When you go into the content, then there are some other special points that need attention. For example, while discussing the content of the speech, it is very important to assess whether the speech is relevant, whether the speech is coherent, whether the person's speech velocity or flow is normal or appropriate, whether the content shows bizarreness, so the uh, rationality of the content or the organization of the content, and finally whether the person can repeat when asked to repeat, or is the person repeating when not asked to repeat. So these are again a few bare minimum things you can look for. So I will explain them one by one and then come into the physiology behind it. When we say the volume of the speech, it means how loudly you are speaking. Now, loudness of speech can be contextual. It can vary from one situation to another. So if you are far away from me, I can shout at you. If you are very close to me, I can almost whisper to you. Or it can also depend on the context of what I am talking about. If it is something which has some kind of a situational taboo, then maybe I will be whispering. If it is something that is funny, I can say it aloud and make other people laugh. But if the volume is consistently low, and even if the patient is trying, he or she is unable to speak loudly, that means there is some problem with the voice generating apparatus or the larynx, which is impairing voice production. And when the volume of the speech decreases, this decreased volume of the speech is also known as dysphonia or hypophonia. So dysphonia means decreased volume of the speech, and it usually indicates a laryngeal problem. When there is a problem in articulation, it is known as dysarthria. And it usually involves a problem in the articulation organs. And this includes the tongue, the teeth, the palate, the lips, etc. So you know that in Hindi, in Bengali, and in other Indian languages, letters are arranged according to which part of the articulation organ is dominating. So we have labials like pa, pha, ba, bha, ma. So if there is a cleft lip, these particular letters cannot be pronounced properly. There are also dentals like ta, tha, da, dha, na. And if a person has poor dentition or no tooth at all, then those letters cannot be pronounced properly. So in this way, by hearing certain types of words, we can even guess where the problem precisely lies. But in this connection, also understand that the pronunciation of a particular word is also dependent on the cultural variation in dialect. It is also dependent on the nature of the formal education that has been received by the person. These two have to be kept in mind while judging the articulation. Because a person's pronunciation is culturally different from the conventional pronunciation, it does not necessarily mean there is dysarthria. That's a learned way that the person is practicing. More importantly, now coming to the content of the speech. Now, when we talk about the content of the speech, we will essentially talk about these parameters. So content of the speech essentially means what is the person talking about. So first part is relevance. Relevance means, am I talking to the point? Am I talking about something I'm supposed to talk about? So for example, you ask me what is your name, and I start talking about my favorite food. Now my sentence can make sense, but it is not relevant to the question. That means that speech is an irrelevant speech. In a similar manner, Coherence means how the different components of your speech are put together as a unified, meaningful construct. So suppose I am telling three different sentences. Each sentence separately makes sense, but together they don't make any sense. So if I say something like, say, I got up early in the morning, there is a corona pandemic going on, and um, I think there will be another class on Monday. These three things are apparently not connected. So my speech is not coherent. Usually incoherent speech is usually irrelevant as well. Talking about velocity or flow, it is how many words or syllables I am compressing per unit time. That is the speed of my talking. Now, the speed at which we speak depends on many factors. If you are in a hurry, you will speak in a hurry. Or if the content that you are talking about is something that excites you, that makes you angry or annoyed, maybe your flow of speech, which is also called pressure of speech, that will increase because you are agitated. If a person is depressed, the flow of the speech can slow down, or the flow of the speech can slow down because there is a fatigue in certain muscles, and so the muscles cannot contract rapidly. So there are so many possibilities that determine the flow of the speech. A person who is agitated and psychotic or in a manic phase might have a greater pressure of speech. A person who is catatonic or depressed may have a very paucity of speech and may become even almost mute. Then comes the organization and rationality. That is, whatever the person is saying, is it making sense? Uh, so there are delusions and hallucinations that a person with schizophrenia can suffer from. And what the person is suffering often becomes the chief complaint of the patient. And so the content of the speech can give you idea to the perceived hallucination of the person or the held delusion of the person. The person can come and say that I have this intuition that a satellite orbiting the Mars is monitoring my activities. Now, apparently there is no problem with the sentence. Maybe my question was, what is your problem? So the answer is a relevant answer. The sentence is coherent. Maybe the flow is also okay. And there is no dysphonia, there is no dysarthria. But what the person is saying doesn't make sense, at least in our day-to-day practice. So it is an irrational speech. It's a speech which has elements of unreality. And therefore it can be called an irrational and unreal speech. And maybe we will investigate further to see if the person has any delusion of control or paranoid delusion or is hallucinating something. Finally comes repetition. Some patients with certain disorders have a tendency to repeat even when they are not asked to repeat. For example, in patients with dementia, there is a phenomenon called perseveration, where the person is constantly repeating the same word again and again. In certain patients with schizophrenia or other forms of psychosis, there can also be echolalia. They will keep repeating what the doctor is saying. So if the doctor asks, how are you? The patient will say, how are you? That is one form of repetition we are talking about. Also, sometimes we ask the patient to repeat. And in certain disorders, for example, in disorders of the arcuate fasciculus, the patient cannot repeat. And in such cases, if you say a word and ask the patient to repeat, repetition will be hampered. So how do we remember all these things? Let us first understand how speech is generated and how problem at various levels of speech processing and output can lead to all these disorders. So our next topic of discussion is the physiology of speech and pathophysiology of speech disorders. Speech is essentially a spoken language. It is a verbal communication between two individuals. And it is actually a very higher function because language is not what we are born with. It is something that we have invented for easier and more complex communication. So how is speech neurologically mediated? There are certain areas of the brain that help in speech generation. Near the lower part of the frontal lobe, we have the Broca's area. Near the upper part of the temporal lobe, we have the Wernicke's area. And these two are connected by a bundle of nerve fibers known as arcuate fasciculus. So how do they mediate the speech production and the speech output? Let us understand. So getting back to this again. So just a minute. If I draw a word diagram depicting the circuitry of speech, it will look something like this. Near the upper part of the temporal lobe, somewhere, we have the hearing center. So in the superficial temporal gyrus specifically, we have the auditory area. Whatever we hear, that flows into, that reception flows into the comprehension area, also known as the Wernicke's area. From the Wernicke's area, outputs go in different direction, and one major direction in which it goes is a part of the frontal lobe known as the Broca's area. The Broca's area is connected with the motor areas of the brain concerned with movement of the larynx, pharynx, face, etc. Now, what happens when a question is asked? So if there is an auditory input, that auditory input finally feeds into the central auditory pathway and reaches the auditory area. The auditory area feeds this into the Wernicke's area. The Wernicke's area is an area of comprehension where you get the meaning of the question. And this comprehended question now flows to the Broca's area by a bundle of nerve fibers. And this bundle of nerve fibers is the arcuate fasciculus. Arcuate means carved and fasciculus means bundle of nerve. So it's a carved bundle of nerve fibers that connect the Wernicke's area with the Broca's area. The Broca's area generates a response. So it is the motor area of the speech. And once it generates a response, it sends the signal to the motor areas of the brain. The motor areas of the brain now stimulate the appropriate parts of the brain and the downstream motor pathway, leading to proper phonation and articulation. So essentially it deals with larynx, pharynx and other parts that result in an answer, a verbal answer. So this is how the circuitry of speech is organized. Now lesions can happen at various levels of this, and this can impair our understanding of the speech, our production of the speech, etc. So let us see what are the levels in which lesions can happen. So technically, there may be a lesion in the Wernicke's area. So the Wernicke's area may be affected. That is one possibility. So I will label this as possibility 1. The second possibility is there may be a lesion in the Broca's area. I'll label this as possibility 2. There may be a lesion in the arcuate fasciculus. And this is our possibility 3. There are chances that multiple areas will get affected. That is possibility 4. So these are the possible areas where damage can occur. Let me now slightly complicate this circuit. There are also certain parts of the brain having functions similar to the language function. For example, there is a part of the temporal lobe that is responsible for specifically storing names of objects. So if naming is a faculty, that area is close to the angular gyrus. And if naming is the faculty we are talking of, names of different objects are often stored here and retrieved here, and it can directly go to the vernix area and help in articulation of those names when we see them. The question comes, what happens when instead of hearing something, we see or read a question? How is a verbal answer to a read question processed? So when we read a question, obviously it cannot go to the auditory area. It is not an auditory input. In that case, the read question obviously first goes to the visual cortex. From the visual cortex, it goes to an area near the naming area that is very close to the angular gyrus. And this angular gyrus has the ability to convert the read words into a form that is understandable by the vernix area. Because you see from the diagram that vernix area could only comprehend information that is given in auditory form. So the angular gyrus now modifies the visual input in such a way that the neural impulse can be read by vernix area. So directly from the visual cortex, vernix area cannot be stimulated, but via the angular gyrus, the vernix area can be stimulated. So one possibility of damage is also at the level of the angular gyrus. Let us name this possibility 4, and the possibility that multiple areas can be damaged, let that be possibility 5. So let us see what would be the outcome of damage to these different areas of speech. As I told you that vernix area helps in comprehension, in understanding a hard question. Broca's area formulates the answer into a motor map as to which part of the motor cortex should be stimulated in what orchestrated sequence so that the organized speech will come out. Arcuate fasciculus connects them and probably also helps in repetition. The questions that are read out instead of heard, they are processed in the visual cortex, travel the angular gyrus, and then they enter the vernix area. So let us first understand at what level speech interruption can occur. So if you see this carefully, the first area of damage was in the vernix area. So what is very obvious here is, if the vernix area is damaged, what will happen? Auditory input or even read letters cannot be processed. Which means when you ask a question to a patient who has a damage to vernix area, then the person will not be able to understand what you are saying. Because the person will not be able to understand what you are saying, the patient will either not answer or will give an answer which is totally unrelated to your question. So the speech of the patient here will become irrelevant. But because there are other kinds of stimulus that can generate speech. For example, you can pinch the patient and the patient can say, "This is painful." Now for that, no question has to be asked. That part of the stimulus can generate speech because the speech generating area, that is the Broca's area, is still intact. So the patient on her or on his own can say many things, but will not be able to give appropriate answer to your question because the questions do not make any sense. Which means if the Wernicke's area would be called the sensory reception area and the Broca's area the motor area, here the problem lies in sensing the question, not in executing the answer. So in the first option, if we see, in option number 1, the damage was in Wernicke's area. So it typically causes what is called a sensory aphasia. Aphasia is abnormality in speech production, also called Wernicke's aphasia. So how will this be characterized? There will be poor comprehension, because comprehension function will be not there. Patient can speak on her own, so the patient is fluent. Fluent means can speak, whether relevant or irrelevant, but the speech is irrelevant. So this is how Wernicke's area damage will manifest. Now let us assume that the damage is at the level of 2, that is Broca's area. So what are the possibilities we will encounter when Broca's area is damaged? Damage to the Broca's area is also known as motor aphasia or Broca's aphasia. So how will that manifest to us? See, as the circuit from auditory input to auditory area to Wernicke's area is intact. So getting the question, getting the meaning of the question is not a problem. So there will be normal comprehension or intact comprehension. So the patient will understand whatever is being asked. But the patient will not be able to speak because the thought cannot be processed. And so the patient will be non-fluent. Meaning that the amount of speech has significantly decreased. It can even become 0. And because the patient can understand, so ideally patient's speech should be relevant. But here there is no speech at all. So there may be a relevant communication. Because he or she cannot generate speech, he or she may be able to write. Because Broca's area does not control the writing part. The Broca's area only controls the speaking part. So maybe the patient will hear your question and give the answer in writing. But when you ask the patient to say the answer, the patient will not be able to say. That loop of the circuit is not working. So this is Broca's area damage causing motor aphasia or Broca's aphasia. So what will happen when the arcuate fasciculus is damaged? If the arcuate fasciculus is damaged, the information from Wernicke's area will not be conducted to the Broca's area. So what will happen is known as conduction aphasia. So what happens here is also known as conduction aphasia. So how will the patient present to you? The patient can see the loop from auditory input, auditory area, Wernicke's area. This is intact. So there will be proper comprehension. There will be good comprehension. But although there is a good comprehension, the information does not reach the Broca's area. As the information does not reach the Broca's area, so there is no link between question and answer. But because Broca's area is intact, spontaneous speech can develop to pinching, to sensory stimulus all around. Only speech in response to a question cannot be generated. So there will be fluent patient, spontaneous speech is present. But the problem is that there is no link between the question and the answer. And therefore, the speech is typically irrelevant. And it is often called a jargon speech. So it is not only irrelevant, it's also jargon. Just words are combined to make a sentence and there is no meaning to it. One way to differentiate this from Wernicke's aphasia is that the patient cannot repeat when asked to repeat. Because the arcuate fasciculus also plays a role in repetition of words. So repetition function is lost when the arcuate fasciculus is damaged. When the angular gyrus is damaged or the temporal lobe is damaged close to the naming area, so I'm calling this the naming area because its precise location is a matter of doubt. This causes no recall of nouns specifically. It's very interesting to see that we have a special area in the brain that only stores nouns. And this no recall of nouns will lead to a phenomenon which is called circumlocution. Circumlocution typically means holding your nose in the roundabout way. That means because you cannot remember the name of an object as a pen, you describe it as that thing which is long, has ink in it, and we use it for writing. So in this way you say. Maybe you also forget the word ink. Then you say that thing with that black thing in it that is used for doing this. So in this way you express. So your idea of the object is clear, only the names cannot be understood. So instead of using specific words, you try to describe it in detail. And this is called circumlocution. So that can also happen in patients with a naming area defect. And this is sometimes called anomic aphasia or nominal aphasia. If the damage extends to the area of angular gyrus, I'm using the same letter here, and the area that converts a visual information comprehensible by the Wernicke's area, if that part is lost, so the patient will be able to understand spoken words but not be able to understand written words. And this is sometimes known as word blindness. So a word when seen cannot be understood, but when heard can be understood. That is why this phenomenon is also sometimes known as word blindness, because a question which is seen on a paper cannot be read, but that which is spoken out can be understood. I hope this is clear to all of you. If there is a damage to more than one area, particularly both Wernicke's and Broca's, that is represented by option 5 here, then obviously you will get all types of combinations together. Patient will be totally mute. So if there is both motor plus sensory aphasia, these conditions are often not compatible with life because such extensive CVA or cerebrovascular accident will not selectively damage these two areas. That means many other areas in the brain have also been damaged. So in that case, there will be no comprehension, no spontaneous speech, that is patient is non-fluent, and whatever small thing the patient is speaking may be totally irrelevant. And this phenomenon has also been called global aphasia. In reality, such isolated aphasias are often not seen. Aphasias are almost always mixed or global in nature. The reason is that the commonest cause of injury to these centers is a cerebrovascular accident. And the cerebrovascular accidents occur along territories of artery, not along territories of function. And so mixed features are more common than an isolated feature. But reading the isolated features is important because that helps you understand which parameters have been mixed. So you understand the extent of the brain damage. What I did not discuss before coming into this is how do we define aphasia? Now you understand what is aphasia. It is not simply a disturbance in speech. A disturbance in speech comprehension and production without any anomaly of vision, hearing, and articulation. So cranial nerves should function properly. There is no problem in hearing, so the auditory pathway is normal. There is no problem in the eye, visual pathway is normal. There is no problem in the motor pathway leading to phonation and articulation. The problem lies in between them. So it is a problem in speech production that results from abnormalities in brain areas other than cranial nerve paralysis. If there is a cranial nerve paralysis, we cannot call it aphasia. So I hope this idea is clear to you, and based on this, we can do an assessment of speech. Now, getting back to the remainder of our discussion on the nervous system examination. So when we talk about the motor system examination, the first question that comes to your mind is, how is an idea converted into an action? So suppose you are thinking of playing football, or you are thinking of cooking something, you are thinking of playing the guitar. So how is this thought of doing something, plan of doing something, finally getting converted into a very coordinated movement of the extremities and leading to that action? So what are the steps that lie in between? If we understand this, it will be very easy for us to understand at which level this can be interrupted. And so in a clinical patient, we can calculate where the problem is occurring. So let us understand this very fundamental thing, how an idea is converted into an action. I'm clearing this drawing. So we know that in the brain, there are different areas associated with thinking, planning, orienting us to the environment, and also movement. When we have an idea of doing something, this idea generates in different parts of the brain. So the areas of the brain that are responsible for generating such ideas include the prefrontal lobe, it includes the somatosensory area, it includes the premotor area, and also the supplementary motor area. So these four parts of the brain are important with development of an idea, of a movement. You might wonder, why is the sensory area a part of the planning of movement? Think very carefully. If your sensations are not working, you have no orientation to your environment, to your surrounding, then how do you know how you are going to respond to the surrounding? For example, if you do not know where the kitchen is, if you cannot see where the various food materials are kept, how can you do a motor planning of the cooking? Because that is more than the recipe. It's about procuring that thing, holding that thing, scooping out something with a spoon, stirring it in. These plannings cannot be done unless you see them, unless you smell them, unless you hear from someone where certain things are kept. So sensory stimulus keeps us in the reality, and it is based on the surrounding reality that we make plans about compromising with it, cooperating with it, or altering it. That is how motor plans are made. So without sensation, it is absolutely very difficult to plan a movement. That is why it is no wonder that a large part of the pyramidal tract fibers also originate from the somatosensory cortex. So these areas help in understanding the surrounding, planning the movement, and finally, information from all these areas converge into the final common area where the information has to go. That is the primary motor area. That is the precentral gyrus. This is where the neurons are mapped in the form of a homunculus representing different parts of the body. So if you stimulate a group of neuron, your hands will move. If you stimulate a part of the neuron, your lips will move. And in this way, the whole body has been mapped in the precentral gyrus. And this forms the primary motor area. So ideas develop in different parts of the brain. In the prefrontal lobe, premotor area, somatosensory area, in the supplementary motor area, and they converge their input into the area where the body's movement structure has been mapped out. And that is the primary motor area. When the primary motor area receives the input, it plans out which muscle will contract after which muscle and what kind of movement should happen. This plan is a very elaborate neurological plan. And once this plan has been made, once it has been planned out, the plan first of all goes straight down the descending tracts to supply the spinal motor neurons where the work will be executed. But parallel with that, the plan also moves to two important regulatory centers of our motor system. It goes to the cerebellum and it goes to the basal ganglia. The cerebellum and basal ganglia both relay at the thalamus. And the basal ganglia gives input to thalamus. Thalamus feeds back to the motor area. Cerebellum gives input to thalamus. Thalamus gives back information to the motor area. And there are also mutual communications between them. I'll tell you the importance of these two parallel regulatory systems. Now, the information that already traveled below to the spinal cord this goes to the individual muscles. And these muscles will contract. And bring about changes in position, in equilibrium, in posture. So the muscles contract and cause movement activities change in position, tone of muscle, and also equilibrium, that is balance. Remember, when such changes are happening, your sensory system is constantly monitoring it. So the moment you are throwing a ball, you are also seeing it with your eyes. You are also finding the batsman moving in a particular position. You are seeing the audience either blaming you or applauding you. These are all sensory inputs that are constantly coming in. You are cooking something, the color of the thing, the smell of the thing is giving you constant feedback. Sometimes the taste of the thing, that whether the cooking is going in the right direction. You are writing something, but as you are writing, you are also looking at your writing. And so that is giving you a visual input as to where there has been any spelling mistake, any handwriting differences, etc. So constantly things are getting monitored. When you are doing an unconscious activity even, that is getting monitored by your pressure receptors, touch receptors, position receptors, or the proprioceptors in different parts of the body. So constantly there is a sensory surveillance, a sensory supervision of the activity that is going on. And now I'll ask you a question. What is the most common subcortical station, that is area where everything ends, for sensory inputs? What is that part of the brain below the cortex where most of the sensory inputs will end and relay? I've started receiving answers. Yes, most of you are right only. The answer is thalamus. And now you see, look at this diagram that we have drawn here and try to understand how things are now getting regulated. So what happens here is, whatever was happening is monitored by the sensory system. So there is a sensory surveillance or supervision. And this sensory surveillance can be done by spatial senses as well as general senses. And after this sensory surveillance, the information that we receive feeds back into the thalamus. So now you see a linear diagram that we had initially drawn is now becoming a number of loops. So starting from the beginning now, how is our movement executed from a simple idea? The idea that forms in the brain that is generated in prefrontal lobe, premotor area, somatosensory area, and supplementary motor area. Ideas from there converge onto the primary motor area. And it is this primary motor area that will finally give a neural signal downwards. No, so the primary motor area now plans out a blueprint of the instruction that first you do this, then this muscle will contract, then this muscle will contract, and that information flows down the spinal cord to the motor nerves. But when this is happening, simultaneously, the information also goes to cerebellum and basal ganglia. So it is a way of saying that when the instruction goes down to the spinal cord, one Xerox copy of the information goes to the cerebellum, another photocopy of the information goes to the basal ganglia. Now, immediately muscles will contract, certain activities will happen, and this will cause a sensory surveillance. The sensory system will understand how far the work was done. And in microseconds of time, the report, the analyzed report will come to thalamus. Now you look at the circuit, you can see that the thalamus had received the initial photocopy from cerebellum and basal ganglia. And it is now receiving the report from the sensory system. So it compares the two systems side by side. It compares the two reports, the initial plan and the final execution. whatever difference is there between the two, what was supposed to be done and what is actually done, that is called the error of the system. That error is now integrated into the motor area. A new plan is made and it again flows down. That is the corrective response. To that, again, there will be sensory surveillance and again information goes back. And now again, the second and the third information are read out by the thalamus, and any difference between the two is now the error of the system. That error will again be fed into the primary motor area. And also the error will be parallelly fed into cerebellum and basal ganglia. That is why the pathways are bidirectional. The coordination errors are mostly handled by cerebellum, and the planning errors are mostly handled by the basal ganglia, although both of them participate in planning and coordination. But major part of the coordination is done by cerebellum and major part of the planning is done by basal ganglia. So this is a very simplified overview of how an idea is ultimately translated into action and is constantly monitored by the activity of basal ganglia, cerebellum and thalamus. Is this clear to everyone? Okay, so we move on to the motor system examination now. So now that we understand how an idea is converted into an action, final action is executed by muscles. We know that we can classify muscles in different ways. But in clinical examination, the easiest way to classify muscle is to call them the proximal group of muscle, that is the axial muscle, like the gluteus maximus, like the erector spinae, like the neck muscles, the hip girdle muscles. These are the proximal group of muscle. And the finger muscle, the toe muscle, these are examples of distal muscles. Now, the basic difference between their action is, although any muscle performs a large type of function, but in general, the proximal group of muscles regulate posture and equilibrium. They help us to stand, they help us to sit down, they help us to bear the weight of the body. Whereas the distal muscles, like the finger and toe muscles, usually help in skilled voluntary movement, like writing, painting, playing a musical instrument. So these are the activities that are done by the distal group of muscle. But of course, I tell you that this is an oversimplification. In certain situations, the distal muscle can actually help in posture and equilibrium. For example, when you are holding onto something, when you are falling down. Similarly, proximal group of muscle can also do skilled voluntary movement, like when a person is dancing. So there is an overlap between the two muscle groups, but usually the proximal muscles are bulky and they are mostly involved in posture and equilibrium. The distal muscles are much thinner and tendinous, and they are more importantly involved in regulation of skilled voluntary movements. The motor neurons that innervate these muscles are broadly divided into lower motor neuron and upper motor neuron. Now, before I get into this, this has to be understood. And there is often a lot of misconception regarding the lower motor neuron and upper motor neuron. You can even understand this looking at this only, this diagram only. Look very clearly into this diagram and you will see something. See, this is where the muscle is located. So this is the muscle. The final executor of movement. So any neuron controlling the activity of this muscle is a motor neuron. So even this is a motor neuron. These neurons are also motor neurons. The neuron that is in direct contact with the muscle, that is directly innervating the muscle, that neuron is called the lower motor neuron. All other neurons that lie above it, it can be one neuron, it can be 100 neurons. All of them are upper motor neurons. It does not matter which tract the neuron belongs to. It can belong to pyramidal tract. It can belong to extrapyramidal tract. It can belong to specifically other tracts like vestibulospinal tract, rubrospinal tract. The name does not matter. Any neuron other than the final neuron that innervates the muscle is an upper motor neuron. So both pyramidal and extrapyramidal system neurons are upper motor neuron, and the final neuron coming out of the spinal cord and touching the muscle is the lower motor neuron. And this final neuron which touches the muscle is usually also known as alpha motor neuron. And a very few gamma motor neurons. So alpha motor neurons and gamma motor neurons are examples of lower motor neuron. And all neurons involved in the descending tracts, that is both pyramidal and extrapyramidal, they are examples of the upper motor neurons. Is this clear to all of you? What is a lower motor neuron and what is an upper motor neuron? So now coming back to what we were discussing. So neurons that regulate motor activities are the motor neurons. The neurons can be lower motor neuron, that is the final neuron that touches the muscle, and upper motor neuron that includes all neurons of pyramidal and extrapyramidal system. Now, we can divide it into pyramidal and extrapyramidal. That is one way of classifying. Another way of classifying, which is more logical in clinical practice, is based on the position of the descending bundle in the spinal cord. Those neurons that are placed outside the spinal cord in the lateral portion, they are called the lateral system, the lateral descending system, or the lateral system of upper motor neuron. And those nerve fibers which are placed medially in the spinal cord, they are the medial descending system or the medial upper motor neuron systems. The lateral descending systems are the lateral corticospinal tract and the rubrospinal tract. All other descending tracts, the anterior corticospinal, vestibulospinal, reticulospinal, and tectospinal, are examples of the medial system. Again, before I go into discussion of these tracts and what they do, let us quickly understand this in a very simplified way. So, the naming of these tracts is totally based on where in the brain they start. So, if there is a group of neuron that starts in the cortex and finally goes down to the spinal cord, then this will be obviously called the corticospinal tract. Similarly, if there is a group of neuron that start in the cortex and go down to the cranial nerve nuclei in brainstem. The brainstem is also called the bulb. Then that will be called corticonuclear tract or corticobulbar tract. Again, in a similar manner, suppose a tract is starting from the red nucleus. Red nucleus is slightly below the cortex. And this tract goes down to the spinal cord. then that will be called the rubrospinal tract. Rubro means red. If there is a part of these descending fibers originating from the superior colliculus, which is also synonymously called the tectum or the midbrain, then the tract that descends from there to the spinal cord is the tectospinal tract. If there is a tract that is originating from the vestibular nucleus, actually there are more than one tracts coming down from here. So there are two tracts basically coming down from the vestibular nucleus. And this forms the vestibulonuclear tract. Similarly, from the reticular formation, the midbrain reticular formation in pons and medulla, tracts originate, one from the pons and one from the medulla, and terminate in the spinal cord. Accordingly, they are called the reticulospinal tract, pontine and medullary. So naming them once again so that you remember, this is the corticospinal tract, this is the corticonuclear tract or corticobulbar tract. Because these tracts pass through the pyramidal eminence, these two tracts, they are together also called the pyramidal tracts. Then you have the rubrospinal tract. The corticospinal tract and the rubrospinal tract together form the lateral system. Rest of them are all in the medial system, and they include the tectospinal tract, vestibulospinal tract, and reticulospinal tract, which is also a pontine reticulospinal tract and medullary reticulospinal tract. So I hope the basic outline of the descending tracts are clear to you. It only shows where the information is originating and from there how the information is going down. And after reaching the spinal cord, depending on which tract we are talking about, their main areas of termination, that is also different from different tracts, but usually they will end in lower motor neuron. That is constant. They will all end in lower motor neuron. Some will end in the alpha motor neuron. Some will end in the gamma motor neuron. Some will end on the neurons of flexor muscle. Some will end in the neurons of extensor muscles. Some will affect the medial muscles more. Some will affect the lateral muscles more or distal muscles more. That is the only basic difference that these tracts have. But ultimately, they will all terminate on the lower motor neurons because these are the upper motor neurons. So some have affinity more for alpha than gamma. Some end on both. Some specifically affect the flexor, some extensor, some medial, some lateral, some upper extremity, some mostly lower extremity. And there is a huge amount of overlap between their functions also. So that is how all these tracts are going to terminate. Now I will go into discussion of certain tracts and their applied importances. Up to this, is this clear to everyone? Great. So as we were discussing, so there are different motor neurons, lower and upper motor neuron. The upper motor neurons, as you can see here, they include the lateral system and the medial system. The lateral corticospinal tract is the main corticospinal tract, and rubrospinal tract, they are the lateral system. A minor part of the corticospinal tract, the anterior corticospinal tract, along with the other tracts, the vestibulospinal, reticulospinal, and tectospinal tract, they form the medial system of the spinal cord. Now, details of this can be learnt later. That is not our concern today. What is important is, what is the important learning how these tracts originate, descend, and end? How is that going to help us in diagnosing the patient? I'll take example of a few tracts and tell you how this is going to help us. In general, these tracts follow a very simple rule. For pyramidal tract, the fibers originate in the brain. They travel through the internal capsule. At the lower end of the medulla, they cross over to the opposite side. And then they end at various levels of the spinal cord over the anterior horn cell of lower motor neuron. That can be alpha motor neuron or gamma, but for pyramidal tract, they mostly end on alpha motor neuron. And these alpha motor neuron finally innervate the muscle. It's as simple as that. So fibers of the left side cross over to the right side at the level of medulla, and then they innervate the muscles of the right side. Fibers of the right side will cross over at the level of the medulla and innervate the muscles of the left side. Those fibers which do not cross, they are about 20% of the fibers. They descend anteriorly instead of descending laterally. And that forms the anterior corticospinal tract. But although they are not crossing, after reaching the final destination, it crosses to the opposite side and then supplies the opposite muscle only. So as a general statement, pyramidal tract fibers control muscles of the opposite side. They either change their location at the level of the lower end of the medulla, or they change their location at the segment in which they are supplying. But ultimately they change their location and they supply the opposite side. That is the general overview of the pyramidal system. Also interesting is the fact that the pyramidal system originates not only from the motor cortex, but about 40% of the fibers originate from the sensory cortex. I hope you will understand the logic behind this, because there is a constant sensory surveillance, and that information is fed into the pyramidal system in a constant way. So when we examine the motor system, what are the points that we look for, and what are the abnormalities we can find there? The examination of motor system mainly involves these 7 points: bulk or nutrition, tone, power, coordination, reflexes, gait, and involuntary movement. And out of this, you have seen that reflexes and gait can also be discussed separately, if you remember to discuss it. So I will go one by one through this and correlate this with our understanding of the muscle physiology, how these changes happen and what it means to get a particular finding. First, coming to the bulk or nutrition of the muscle. Bulk or nutrition simply means how thick is the muscle. Ideally, the bulk should be equal on both sides because our bodies are symmetrical. There are conditions where muscle bulk can increase. That is known as hypertrophy of muscle. There are conditions where muscle bulk can decrease. That is called atrophy of muscle. So what are the ways in which the bulk can be measured? The easiest way to measure bulk of a group of muscle is wrap a measuring tape around your hand and find out the circumference. Of course, we cannot measure bulk of individual muscles by this method. To do that, we have to do some special study. Like we can do a dual absorption CT scan or MRI scan. But clinically, we can only find the overall bulk of the muscle because obviously we cannot dissect a living person. So there are standard landmarks where the measurements have to be taken. For example, for the upper arm, we take the mid-arm circumference. That is, you take the midpoint between the olecranon process and the acromion process, and at that level, you take a reading with a measuring tape and measure the circumference. That is the mid-upper arm circumference, also called mid-arm circumference. Similarly, for the forearm, between the olecranon process and the prominence of the wrist, you take the middle point and you take the measurement. Similarly, on the thigh, you look at the greater trochanter, the most bulging bony prominence, and the lateral condyle of the femur, take the midpoint and measure the circumference. For the lower limb, either you can take bony landmarks, like you can take the prominence of the tibia and the lateral condyle and take the midpoint, or you can measure the most prominent point on the calf muscle. So there are different ways. You don't have to memorize that. What I'm trying to say is that when we measure bulk or nutrition of the muscle, we measure bulk of a group of muscle. We cannot measure a single muscle by clinical examination. So why is it important to test the bulk of the muscle? It is seen that the bulk of the muscle can change in diseases. In lower motor neuron paralysis, there is a nutritional atrophy of the muscle because the lower motor neuron secretes many growth factors and regulates the microcirculation of the muscle. So if the lower motor neuron is cut, the muscle's nutrition will be hampered and the muscle will start to atrophy. In upper motor neuron lesion, the damage to the muscle occurs, but not due to lack of nutrition. It is because the muscle is not used. Use-dependent hypertrophy does not occur, and there is a disuse atrophy of the muscle. That is always much less significant compared to the nutritional atrophy, which can be very severe. Coming to assessment of muscle tone. How is muscle tone evaluated? Before understanding muscle tone, we have to understand what is muscle tone. Suppose there is a rubber band and you are stretching the rubber band to get an idea of how stiff or how elastic the rubber band is. This passive detection of the elasticity of the rubber band is evaluating the tone of the rubber band. In a similar manner, if I compare this with a muscle, so what is tone? Tone is the resistance felt by the examiner while passively stretching a muscle. So tone is the resistance that is felt by the examiner, not while actively, while passively stretching a muscle. So suppose this is, I'm going to measure the tone of the biceps. You don't ask the patient to contract the bicep. You simply fold the hand like this and try to see how much stiff is my bicep muscle when you are stretching it. So when you are moving against the movement of bicep muscle, you are actually measuring the tone of the bicep muscle. So in tone assessment, the patient should not contract the muscle. Patient will relax the extremity as much as possible. You move the extremity to and fro, and when you are going away from the axis of movement of that muscle, you are assessing the tone. Like the axis of movement of rubber band is towards the center. So when you are stretching it away from the center, you understand the tone of the rubber band. So this is how tone of the muscle can be measured. Increase in muscle tone is known as hypertonia. And decrease in muscle tone is called hypotonia. Different clinical conditions can cause hypertonia and hypotonia. And we can measure tone by a modified Ashworth scale, which I will give you in the PDF for study. And you can see how muscle tone can be evaluated. So hypertonia can typically happen in upper motor neuron lesion, in anxiety. And hypotonia or reduced tone can be seen in lower motor neuron lesion, in sleep, and in hypothyroidism. The question is, why will muscle tone increase in upper motor neuron lesion and decrease in lower motor neuron lesion, where both of them are basically paralysis? In both cases, nerves are being cut and information from the center is not reaching the muscle. So why in upper motor neuron lesion there will be increase in muscle tone, and in hypotonia and lower motor neuron lesion causes decrease in muscle tone? Can someone write in one line what is the mechanism by which upper motor neuron lesion can increase muscle tone? So I'm getting a few answers. Yes, I'm getting a few answers and many of them are correct only. So this is because the upper motor neuron has a very peculiar way of dealing with the lower motor neuron. The upper motor neuron is one way of understanding, the way I usually say. The upper motor neuron behaves like a very strict boss. It will tell the lower motor neuron what to do, but at the same time, it will prevent it from overdoing it. So it's like the upper motor neuron will say, contract this muscle. And when the contraction increases, the upper motor neuron will say, not that much. That's sufficient, whatever contraction has happened. This, in summary, means that the upper motor neuron, apart from instructing the lower motor neuron what to do, has a tonic inhibitory influence on the lower motor neuron. It prevents overdoing of activities. So in absence of the upper motor neuron, of course, no information is coming down. But the normal reflex activities that do not require upper motor neuron, they start to increase because the inhibitory control of upper motor neuron is lost. This I will explain by discussing with you how muscle tone is normally regulated. Once you understand this, explaining and understanding this mechanism will become much easier. So the question is, how is muscle tone regulated? Regulation of muscle tone occurs at the level of the spinal cord and also above the level of the spinal cord. The regulation at the level of the spinal cord is known as segmental control, also sometimes called spinal control. And regulation from above the level of the spinal cord is known as supraspinal control. So let us understand what is segmental control and what is supraspinal control. Segmental control of the muscle tone occurs by the muscle spindle. So I find that some students have difficulty in understanding how muscle spindle operates. So I will start with a discussion of the operation of the muscle spindle very briefly. See, if this is the spinal cord, this is the posterior root, this is the anterior root, and this is one half of the spinal cord, of course. We know the Bell-Magendie law. The posterior root always transmits the sensory neurons and the anterior root always transmits the motor neurons. Now, suppose there is a muscle. This muscle contracts under the influence of its own motor neuron, which we will call the lower motor neuron or the alpha motor neuron. So let us assume this is the alpha motor neuron. And the alpha motor neuron innervates the muscle and helps the muscle contract. This is the cell body of the alpha motor neuron. As the muscle contracts, the stretch of the muscle is sensed by sensory receptors. And stretching of the muscle is sensed by a special type of receptor which is known as muscle spindle. So it's a modified muscle fiber which lies in parallel arrangement with the muscle, and this receptor is a stretch receptor. The name of this stretch receptor is muscle spindle. So this is called muscle spindle. Now, what does the muscle spindle do? The muscle spindle is stimulated by stretch. So whenever there is stretching, the muscle spindle will get stimulated. So when the muscle is contracting, muscle spindle is relaxing. When the muscle is relaxing, muscle spindle is getting stretched and it is contracting. So whenever muscle spindle is stretched, the stretch goes above as a sensory input. As in all sensory neuron, the cell body lies outside and forms the dorsal horn. And it goes inside now. After going inside, it innervates and connects with the alpha motor neuron. And as it connects with the alpha motor neuron, it stimulates the alpha motor neuron. So try to understand how this reflex is getting operated. As the muscle is getting stretched, that is relaxed, stretching is relaxation. And contraction means length of the muscle is decreasing. That is actually making the muscle spindle flaccid. So relaxation stimulates the muscle spindle. And the muscle spindle sends sensory input now. It sends sensory input to the spinal cord. This sensory input will now cause stimulation of the alpha motor neuron. And now the alpha motor neuron carries information and releases acetylcholine on the muscle. So the muscle contracts. So let us see the reflex arc here. Any reflex can be broken down into a few basic fragments. So here the stimulus is stretch, that is relaxation. Here the receptor is muscle spindle. That is a stretch receptor. Here the afferent or the sensory nerve is the nerve originating from the muscle receptor, that is the muscle spindle. This nerve is also known as the 1A or 2 fiber. Then comes the center. As you can see, the center of integration is the spinal segment from where the motor root arises. Then comes the efferent nerve or motor nerve. At least in this case, the motor nerve is the alpha motor neuron, shown here in red color. The effector organ are the muscle fibers. The muscle fibers are also conventionally called extrafusal fibers. So extrafusal fiber is nothing but muscle fiber, because the muscle spindle is called intrafusal fiber. That is why. So extrafusal fiber is essentially the muscle fiber. And the effect or response is muscle contraction. So you see, we start with relaxation and end up in contraction. And like all reflexes, now there is an error correction. Whatever length of the muscle had increased will now decrease. And therefore, the length and tone of the muscle remains constant. So this is the segmental control of muscle tone. Now with this, there is one more neuron that also operates in the background that we have to understand. Along with the alpha motor neuron, the muscle spindle itself is also stimulated by another neuron, the gamma motor neuron. And this gamma motor neuron is simultaneously innervated by the afferent. So the red one was alpha motor neuron. The pink one is gamma motor neuron. See, the difference between alpha and gamma is alpha motor neuron is the typical lower motor neuron. It innervates muscle fiber. And because it innervates muscle fiber, its response is muscle contraction. Gamma motor neuron does not innervate muscle fiber. The gamma motor neuron innervates the muscle spindle. That is the receptor itself. So what is the effect of gamma motor neuron? The gamma motor neuron shortens the muscle spindle. So if the muscle spindle size decreases, there will be more tension at the end of the muscle spindle. If the size of the or length of the muscle spindle decreases by contraction, then there is more tension, more stretch at the end of the muscle spindle. And stretch is the stimulus for stimulation of the muscle spindle, which means now the muscle spindle becomes more sensitive to stretch and it fires more often. It is very much like tuning the string of a string instrument. If you over-tune it, a slight touch will cause a high frequency note. And that is exactly what the gamma motor neuron does. It tunes or it increases the sensitivity of the muscle spindle so that at the slightest stretch, it will have an exaggerated response. This tuning effect is the effect of the gamma motor neuron. So alpha motor neuron causes the final effect, muscle contraction. And gamma motor neuron, what it does is it tunes the muscle spindle so that its sensitivity increases. Why is this needed? Why do we need to increase the sensitivity of the gamma motor neuron? Suppose you are running. When you are running, your muscles are constantly changing in size. Sometimes they are shortening, sometimes they are lengthening. Now suppose when a group of muscle is relaxing while running, the muscle spindle is stimulated. Now when the muscle contracts, the muscle spindle will no longer be stimulated. Then suddenly tone of the muscle will drop and there is a chance that you can fall on the ground. We cannot allow such extremes to happen, that either there is contraction or there is no contraction at all. So when you are running or doing an activity, you have to maintain the tone of the muscle through the whole range of the movement, whether you are actively contracting the muscle or you are relaxing the muscle. The tone should always be maintained. Otherwise, in all relaxing posture, patient is supposed to fall on the ground. But that doesn't happen. So how is that regulated? When a muscle contracts, its length decreases. As the length of the muscle decreases, now I am continuing a loop here. See, as the muscle contracts, this will cause decreased length of the muscle spindle as well. When actually decreased length of the muscle fibers. As the muscle fibers decrease in length, because the muscle spindle is in parallel arrangement, so the muscle spindle becomes lax. If the muscle spindle becomes lax, the reflex will be abolished, because without stretch, the muscle spindle cannot be activated. But remember that when the sensory neuron was stimulating alpha motor neuron, it was also stimulating the gamma motor neuron. So when the alpha motor neuron was stimulated, the 1A fiber was also stimulating the gamma motor neuron. And as the gamma motor neuron is stimulated, this causes simultaneous shortening of the muscle spindle. As the muscle spindle is simultaneously shortened, so length of the muscle spindle remains proportional to the length of the muscle fiber. And this prevents loss of sensitivity. So this mechanism is very important in exercise and sports. And so alpha and gamma motor neuron are simultaneously activated so that the sensitivity of the muscle spindle remains and tone is maintained in any range of movement. And this has also been called the alpha gamma co-activation because they are simultaneously activated. So this is the segmental control of muscle tone, that is at the level of the spinal cord, how muscle tone is regulated. I hope this is clear to everyone. So going over to the suprasegmental, that is the supraspinal control. So now I think this diagram will make sense to you. And going to suprasegmental control, this is how the different descending tracts will end. Some will end on alpha motor neuron, some will end on gamma motor neuron, some will end on extensor neuron, some will end on flexor neuron, and ultimately the whole body tone will be adjusted. This we have already discussed in some other diagram. As a summary of this is how they operate, but this is not our topic of discussion today. I'll just read this out. This will be important on some other day when we will discuss about different types of rigidities. So the pyramidal tract or corticospinal tract, as I told you, they mainly modulate the activity of the finer muscles, and rubrospinal stimulates the flexors. Reticulospinal, the medullary component, inhibits the extensor and excites the flexor. Pontine component excites the extensors and inhibits the flexors. They have opposite role, and they generally affect the upper limb. Vestibulospinal in the upper limb doesn't affect the upper limb, but helps in the position of head and neck. Whereas in the lower limb, it stimulates the extensors. The tectospinal controls the activity of the head, neck, and eye movement. So this is a very overview or summary of this complicated diagram of how different pathways affect the muscle tone in different ways. Now coming on to muscle power. How do we test power of a muscle? When we test power of the muscle, we ask the patient to contract the muscle. And we put a resistance against the muscle to see how far that can be resisted. So depending on that, we can grade muscle power from normal power to no contraction visible. Now, we also test reflexes. By reflexes, we mean the segmental reflexes that are caused by this stretch reflex only. So you will see whenever we talk about reflexes, we have a tendency to ask, what is the root value of a particular reflex? Sometimes we say the root value of biceps jerk is C5, C6. What is the meaning of the word root value? Look at this diagram very clearly, which we have already discussed. You can see from this diagram that the afferent nerve fibers are entering through the dorsal root. The motor fibers are leaving the ventral root. That is the rule. And the afferents are originating from the same muscle in which the efferent will go. That means in this reflex arc, the sensory and the motor component enter and exit the same level of the spinal cord. And because spinal nerves are mixed nerves, so although in the diagram we are drawing them as different lines, in actual practice, they are bundled together as a mixed nerve. Information is going along the same anatomical nerve and coming down the same anatomical nerve along the same level of the spinal cord. This level of the spinal cord regulating the reflex is called the root value of the reflex. So when I say the root value of biceps jerk is C5, C6, it means the 1A or 2 fiber from the muscle spindle in case of bicep originate and enter the cervical 5 and 6 segment of spinal cord. It integrates in the gray matter of the cervical 5 and 6 segment of spinal cord, innervates the anterior horn cell of the cervical 5 and 6 segment of spinal cord, and the cervical 5 and 6 alpha motor neuron finally comes back and innervates the same biceps muscle to complete the reflex action. So this is what we mean by root value of a particular jerk. This will be important later when we do clinical examination. The root value of the jaw jerk is the third division, that is mandibular division of trigeminal nerve. Biceps and brachioradialis jerk are mediated by C5, C6. Triceps is one level down, that is C6, C7. Knee jerk or the quadriceps jerk is lumbar 2, 3, 4, and ankle jerk is sacral 1 and 2. Coming to coordination. Coordination means whether the different activities of the body are properly interlinked or not, whether they are happening as a smooth single movement as it happens in dance. This can be tested by the finger nose test, where you ask the patient to touch the finger and go away. Again, touch the nose with finger and go away, and repeat the same thing with the eye closed. There is a modified way of doing that also. The examiner can put the finger here and the patient touches the finger and the nose alternately. Again, this can be tried with the eyes closed. A similar test is a heel knee test, where you touch the knee with the opposite heel, go down to the heel, and again repeat the same maneuver. These activities require a lot of motor coordination, and we typically test whether the activities can be done properly. Such incoordination are commonly seen in cerebellar disorders, in disorders of the cerebellum. And so we will discuss in much detail about these tests in our third session, the day on which we will discuss basal ganglia and cerebellum. There is another important test called the Romberg's test or Romberg sign. You ask the patient to stand up with the feet parallel and then ask the patient to close the eye. If the patient is shaking or about to fall, that is a positive Romberg sign. Romberg test is incoordination not due to cerebellar pathology. It is probably due to a problem in the posterior column sensation. So due to sensory defect, these kind of incoordination occur, and so it is also called sensory ataxia. This again we will discuss in greater detail under cerebellum. Now there are different kinds of involuntary movements that can happen. This has to be looked for in the motor system examination. They may be localized to one muscle like fasciculation, myoclonus or tremor. They may be more generalized like chorea, athetosis, hemibalismus and convulsion. The generalized movement disorders we will discuss again under basal ganglia. Localized disorder, under them tremor and fasciculation are the most important. So we will discuss tremor and fasciculation. So coming to what is fasciculation. Fasciculation is sometimes also called fibrillation. Fasciculation simply means an involuntary wriggling movement of a muscle. That is, it looks like the muscle has become like a bag of worm and they are moving around inside, causing isolated contraction of individual muscle fibers. So fasciculation is like a bag of worm movement. It is caused by isolated asynchronous involuntary muscle contraction. We do not know why this happens, but this is typically seen in patients with lower motor neuron disorder. In lower motor neuron lesion, we find fasciculation. the fasciculation probably represents a denervation hypersensitivity, although the exact theory is not known. So we do not really know what causes fasciculation, but the probable mechanism is a denervation hypersensitivity. So although this theory is not a very clear theory, but probably it goes like this. Suppose this is an individual muscle fiber. So I'm not talking of the muscle. I'm now going into individual muscle fibers. The muscle fibers have on their surface acetylcholine. Under normal circumstances, a motor nerve ending with synaptic vesicles in it release acetylcholine. The acetylcholine binds the nicotinic receptor. This causes entry of sodium ion. And this leads to depolarization and contraction of the muscle. That is the usual neuromuscular transmission. Now, if there is damage to the motor nerve, this nerve has been damaged. So there is no more acetylcholine in the vicinity. In absence of a neurotransmitter or hormone, the number of their receptors usually increase. As a result, the number of nicotinic receptor proliferate. This is called upregulation of receptor. This is a general mechanism where hormone or neurotransmitter decreases, receptors increase in number. So if there is an acetylcholine-like substance or even acetylcholine diffusing from the surrounding nerve fibers in some way, in small amount, then that diffusing acetylcholine will now be able to cause activities or stimulation on these receptors. And because the receptors are so exaggeratedly expressed, a small amount, even a nanomole amount of the chemical will now cause a severe contraction. But since it is not its own chemical, it will be rapidly destroyed, it will not last long, and so it again disappears before a full-fledged contraction happens. So these are isolated contraction caused by stimulating chemicals on the overexpressed receptor. That is the only theory. Although there are many fallacies with this theory, we are yet to understand clearly what causes fasciculation. But it is typically seen in lower motor neuron lesion. In upper motor neuron lesion, since the lower motor neuron is intact, so the acetylcholine delivery is never less. So upregulation of receptor does not occur, and so fasciculation is not seen in upper motor neuron lesion. So that is one important aspect. The next important movement disorder is tremor. Now, tremor can be classified in different ways. One way of classifying tremor is based on its frequency. Based on the frequency, it can be a fine tremor when the frequency is more than 10 Hertz. And coarse tremor when it is less than 10 Hertz. Tremor can also be classified based on how it is produced. And it can be static tremor, which is produced at rest, kinetic tremor, which is produced during movement, and a special type of kinetic tremor is intention tremor. And separately, static tremor একটা special type হতে পারে, for example, postural tremor, like the flapping tremor. So tremor can be static or kinetic, depending on whether the patient is at rest or whether the patient is in some kind of a movement. So these are the different types of tremor, and I will come back to tremor again when I will discuss about basal ganglia and cerebellar disorders in the third class. Now, coming to our general discussion, how can lower and upper motor neuron lesions be differentiated? So as we understood, the upper motor neuron has some inhibitory effect on the muscle stretch reflex. As a result, you keep reading. Therefore, their paralysis causes increased muscle tone, which is called spastic paralysis. For the same reason, the gamma motor neuron get overactivated and the reflex arc becomes more fast acting. So there is a hyperreflexia. There is already increase in muscle tone. Muscle mass only shows disuse atrophy, not nutritional atrophy. Fasciculations are not seen. I will talk about Babinski sign later. And all superficial reflexes are lost because superficial reflexes have extensive pathways. So in whatever be the form of paralysis, upper or lower motor neuron lesion, superficial reflexes are always lost. In voluntary movement, there may be a decreased speed because complete paralysis may not happen if some upper motor neurons are still there. And it usually involves a large area of the body because fibers are originating above, where the fibers are compressed and they spread out below. So cutting a small area above affects a large area below. That is one way of looking at it. The opposite happens in lower motor neuron lesion. The lower motor neuron stimulates the muscle, so its absence causes flaccid paralysis, tone decreases, reflex decreases. There is wasting, that is lack of nutrition. Fasciculations are present, and as I told you, superficial reflexes are always lost. All types of movement are lost. The reason is that the final common pathway of movement has been destroyed. Now coming over to the sensory system examination. Although sensory system examination sounds like an elaborate system, but the reason I took it up later is it is the least reliable of all clinical examination in nervous system. Sensation is a very subjective perception. It's not something that you can see. So if the patient is not cooperative and if the patient cannot report properly, then the sensory system examination makes no sense. And that is why sensory system examination is a supplement to motor examination. We cannot or should not detect the level of paralysis depending only on sensory system exam. That will be extremely fallacious in the clinical practice. Try to depend more on motor system examination for localization of a sign and let the sensory system findings support your diagnosis instead of making the sensory system the main focus of your diagnosis, because we usually cannot reach a pinpointed diagnosis using the sensory system. First of all, let us correct one common fallacy that we have learned from the elementary schools. We have always learned that there are 5 basic sensation, 4 special and 1 general. That is basically a misnomer because there are large number of sensations and this is only a small list of different sensations we have. So there are multiple kinds of sensory modalities and they cannot be always classified within 5 categories. So the 5 categories help us remember, but actually there are more than 30-40 different types of sensations. So the sequence is that you touch a pin in different parts of the body and assess for pain sensation. Touch a wisp of cotton in different parts of the body, assess for touch sensation. Touch a test tube with a warm water 5 degrees Celsius above 37 degree and a test tube with 5 degrees Celsius lower than 37 degree for warm and cold temperature. For practical purpose, you can also use a cold metal object for cold sensation. We do not use extremes of temperature. The reason is that it will elicit pain sensation instead of temperature sensation. Vibration can be tested with a tuning fork, preferably of 128 Hertz. And joint position can also be elicited by moving the joint at various angles and asking the patient how the joint is kept. Cortical sensation are the sensation that require higher thought processes. So suppose I'm closing my eye, you touch a part of the body and ask where I have touched. Answering this question means I'm accessing the brain where my body is mapped, and I'm trying to find out the exact location using a GPS system of the brain. So that is called tactile localization. It's very similar to the mechanism in which you can strike over a mosquito when the mosquito is sitting on your body. 2-point discrimination means the ability to find out, you can see here in this diagram, ability to find out whether there is one stimulus point or two stimulus point on the skin. If that area is supplied by one neuron, the body will consider the two stimuli as one stimulus, provided they are simultaneously provided. And if the density of neuron there is very high, then they will be perceived as separate neurons. Stereognosis is guessing the name of the object from the shape. And this requires prior exposure to the object. You should know the object to identify it. Graphesthesia is writing a shape with a probe or with the fingers and asking the patient to name the letter. That also requires the person to be literate and actually know that particular language to identify that letter. So these are the different higher sensations or cortical sensations that we test. Now the question is, how is the knowledge of this sensation helping us in localizing the site of the lesion? You see, this is a map of how body's different parts are supplied by different sensory nerves. This map is a dermatome map. A dermatome is that part of the skin which is supplied by a single sensory nerve segment of the spinal cord. You can see that the map is not very easy to remember, but the map becomes easy to remember if you remember that we evolved from quadrupeds. And so if we stand in a quadrupedal position, you can see the map becomes very easy to remember. So a straight line down the neck shows you that the areas have cervical C3 up to cervical C3 and the trigeminal nerve. From the neck to the hand is the brachial plexus. So essentially C4 to T1 will be covered in the hands. So below the hand comes T2 and up to the umbilicus it is T10. From the umbilicus to the waist it is up to T12. Now the lumbar region is the front part of the leg, sacral region is the back part of the leg. If you understand this anteriorly also, the belt area is the L1, the pocket area is the L2, the thigh area is the L3, and that way you go down. So it's not very difficult to find out the pattern in which the dermatome is arranged if you think in this way, and this helps us identify which particular sensory segment has lost sensation or is oversensitive. Pain is a very important sensation, and understanding pain is important to understand the various diseases that involve pain and the medications that we use to treat pain. Whenever there is injury to certain part of the body, there is release of certain chemicals, inflammatory chemicals. Most important of them are bradykinin, serotonin, prostaglandin, and histamine. They cause expression of more chemicals and receptors on the nerve fiber, and this process has been called nerve fiber sensitization. A sensitized fiber carries this impulse through the dorsal root ganglion, because we know the posterior horn transmits sensation. And once it enters the spinal cord, we can understand from here. Just a minute. So once it enters the spinal cord, it crosses the nerve fibers. Look at diagram B. It crosses over to the opposite side and goes straight up. And then it ends in thalamus. Thalamus is the area of the primary sensation. that is whether there is pain or not, that is first felt by thalamus. The information from thalamus goes to various parts of the cortex, which analyzes the pain and describes the pain. So suppose I have pinched someone. So if the person's cortex is not working, but the thalamus is working, the person will be able to say whether there is pain or no pain. But if I ask that person, what kind of pain was this? Did someone pinch you? Did someone stab you? Did someone put some irritating chemical on you? What is the way you will describe the pain? The person will not be able to describe, because description requires the cortical neurons. Similarly, if the person's cortex is intact and the thalamus is not intact, because thalamus is the first station, all sensations will be lost even if the cortex is functioning. So thalamus is called the area of primary sensation or crude perception. And the cortex gives finer adjectives to the pain sensation and describes the pain. The vibration and proprioception, you can see from diagram A, they enter the body, travel along the posterior column. They do not cross at the level. They cross at the level of lower part of medulla, very much like the pyramidal tract. So their crossing occurs at the level of the pyramidal tract. Then they go straight up, relay at various nuclei, and finally it reaches the thalamus. And from the thalamus, it goes to different parts of the cortex and gives the perception of fine touch and vibration. So in summary, the pain fibers are fibers that cross at the segment and go up. The fine touch and proprioception are the dorsal column fibers that do not cross at the lower level. They go straight up on the same side up to the medulla. In the medulla, they cross to the opposite side and reach the opposite part of the brain. But as a final statement, therefore, always the opposite part of the brain senses the sensation of a particular part. So I think this is clear to all of you. Another thing, in the general examination format of nervous system, we found that we discuss the coordination of bladder and bowel function as part of the autonomic nervous system function. So it is actually very important that we understand how micturition reflex is controlled. This is a very important part to understand even in medicine, because you get questions on neurogenic bladder. If you see the innervation of the bladder, how the emptying and the filling of the bladder is controlled, then it is something like this. The bladder is, let me explain this with a simpler diagram. So suppose this is the urinary bladder. This is the urethra. Urinary bladder, the smooth muscle of the bladder is the detrusor muscle. And we know that in this detrusor muscle, relaxation is caused by beta adrenergic receptor, beta 2 or 3. Contraction is caused by cholinergic nerve, and that is muscarinic receptor M3. So on the beta 2 receptor acts noradrenaline coming from the sympathetic nerves. On the muscarinic receptor acts acetylcholine coming from the parasympathetic nerves. For this reason, we know that the parasympathetic nerves have been called the nerves of voiding, that is the nerves of contraction of the bladder. And the sympathetic nerves have been called the nerves of filling, that is relaxation of the bladder. We know that the parasympathetic division is craniosacral outflow. Therefore, the nerves here must come from the sacral segment. So the parasympathetic nerves come from the sacral division. We also know that the sympathetic is a thoracolumbar outflow. So here it comes from the lumbar segment. And this is the sympathetic division. So the main function of the parasympathetic, as we see here, is bladder contraction and micturition. The main function of the sympathetic is bladder relaxation and storage of urine. That is continence. For voluntary control of micturition, we also have the external urethral sphincter, which is under voluntary control. That means it should be under some sort of somatic nerve control. And this somatic supply also comes from the sacral segment through the pudendal nerve. So the lumbar segment and the sacral segment, supplying the parasympathetic and sympathetic, regulate the autonomic control of the bladder. The pudendal nerve, again coming from the sacrum, the sacral part, is the voluntary control of the bladder. All these activities are controlled by the pons. In the pons, there is a center popularly called the Barrington center, sometimes also called the pontine switching center. And this pontine Barrington center decides when the bladder will contract. The decision of the pons, whether it will stimulate the sacral segment or inhibit the sacral segment, that decision is also under the control of the cortex. Partly. Although pons is more important than cortex in this regard. And the cortex helps us decide whether socially it is appropriate to micturate at a particular area. That is how the learned reflex of micturition develops. This voluntary control to the pyramidal tract is exerted on the pudendal nerve. So even when the autonomic control is urging you to micturate, maybe you are in a situation where micturition is not possible, you try to hold your bladder. That is done by the external sphincter using the pudendal nerve. So this, in summary, as you can understand, is the innervation of the bladder. Then how does the reflex occur? How does stretching of the bladder lead to micturition? Let us see that. Is the nerve innervation clear till now? What are the centers and what are the nerves? I have not discussed the reflex yet. Okay. So we start here with the reflex control. So let us see this picture. Now this picture will be very clear to you. From the lumbar area, you see the sympathetic nerves are coming. From the sacral area, the parasympathetic nerves are coming. And also from the sacral area, the pudendal nerve is coming and supplying the external sphincter, which is a skeletal muscle. This is how the reflex control occurs. The cortex and the pons are constantly communicating with each other. Now, in any reflex, you must know where do you start reading. You start reading this from inside the bladder. That is how the reflex works. So urine collects inside the bladder. That is the first step. The collected urine causes stretch, and this stretch travels via the sensory nerve, shown here with a green color, to the spinal cord. As the sensory nerve travels to the spinal cord, information goes up to the pons. And pons discusses with the cortex whether it is okay to micturate here. If the answer is yes, then pons will send a signal downwards. And this downward signal will go towards the motor innervation of the bladder. So as a part of the motor innervation, the bladder will contract and the external urethra will relax. The external urethral sphincter will relax and urine comes out. If the situation is inappropriate, pons does not fire. So by spontaneous feedback mechanism, the bladder does not contract, and even if it contracts, there is a voluntary compulsion to keep the external urethral sphincter shut down, and so voluntary micturition does not occur. So this is essentially the neural control of micturition. You must get back home and read this in detail because this is very important in clinical medicine. But then what is the importance of learning this? We can guess the level of the lesion even with the bladder anomalies. At various levels, there may be, so there may be damage at the level of the brainstem or the cortex. There may be damage at the level of the sacral segment, damage at the level of the afferent nerves or efferent nerves, and they can cause different kinds of neural anomalies of the bladder. Broadly, the neurogenic bladder can be discussed under three headings: loss of sensory nerves, loss of both sensory and motor nerves, and loss of higher control. There are many other problems also which are mixture of these. So if these three are discussed based on this diagram only, you see, if there is a loss of higher control, that is a section above the sacral segment, so that the sacral segment is dissociated from the pons, then what will happen? Then the local reflex arc will continue to operate, but it will not be under the control of the pons. As a result, as the local reflex arc will not operate without the control of pons, whenever there is a filling of the bladder, patient will micturate, even without an awareness of it, even without the brain noticing that micturition is happening. So there will be spontaneous micturition. Now coming to what will happen when only the sensory component is gone, the green line here. Then as the bladder stretches, the stretch or the pain is not felt by the patient. So the bladder keeps on getting filled. And when this happens for months, the bladder becomes very thin-walled, very large and distended. It is known as an atonic bladder. And after a point where the physical pressure of the urine increases, the urine dribbles down from the urethra. This is known as overflow incontinence. As a final mechanism, if a sacral tumor destroys both sensory and motor component, then what will happen? The mechanism by which this happens is not known, but probably because of destruction of the motor component, there is a denervation hypersensitivity. It is a very modified kind of denervation hypersensitivity where the muscles not only express more receptor, they also grow in size. Its exact mechanism is unknown. So the whole bladder becomes thick, contracted and muscular. The detrusor muscle becomes very prominent with rugosities. And this spastic bladder is always at the verge of contraction. And this leads to an overactive or hyperactive bladder where a little bit of urine stimulates the bladder and there is an urge incontinence. So this is how the neural control of bladder can be understood, and we can also guess at what level things have gone wrong. Finally, coming back to the higher functions, I told you this is a difficult domain to talk about. So under higher function, we discussed about the orientation to time, place, person, memory, recollection, calculation abilities, etc. It's important that after those assessments, you come to a diagnosis as to if the patient is delirious or demented. Both can cause the patient to look confused. But delirium is almost always due to some chemical or organic cause, due to effect of a drug, due to sodium alteration in the brain, due to effect of some head injury. Whereas dementia is a slow degenerative process, where the brain is affected by atrophy. One way to differentiate between a true dementia and a depressed patient who appears to be demented is to ask, what is your problem? If the patient starts giving a list of what the patient forgets, be 100% sure this is not a case of dementia. A person with a true dementia does not even remember what he or she has forgotten. So if the person is recollecting and telling you, I'm getting forgetful over the days, I'm forgetting to carry money to the market, I forgot to carry my mark sheets to my school, that means this person has lack of attention and concentration, but has no dementia. And that is called pseudo dementia, which is often due to depression or hypothyroidism. But when dementia is true in nature and brain has been actually damaged, then the person cannot even recall what is the problem. Instead, the patient presents with paranoid idea. Because he or she cannot remember what is happening all around him or her, he or she will complain that unknown people are coming to the house because he cannot recognize the persons. He will say that he is not given food because he doesn't remember taking the food. And this kind of ideas will come when a person becomes demented. The criteria for diagnosis of dementia is not only impairment of memory. There should also be associated aphasia, apraxia or inability to plan, agnosia, inability to recognize, and disturbance in executive function, that is inability to perform. So it's a global intellectual decline. Dementia can be caused by certain reversible causes, which can be treated with drugs. It can also be caused by irreversible causes. So depending on the precise cause of dementia, the treatment is directed. So in today's discussion, as you saw, our aim was to understand the mechanisms and physiological principles behind the nervous system examination. And in the scheme of nervous system examination, we said that this is the scheme that we usually follow. So psyche is the higher function, speech we have discussed, spine and cranium is basically external examination. Cranial nerves and motor system examination give you idea of the motor and sensory functions in the level of the brain. In motor system examination, you look for tone, power, coordination, bulk, and atrophy. Look for the reflexes that give you idea about hyperreflexia or hyporeflexia at a segmental level. We discussed the control of bladder and bowel. We discussed how sensory system can be evaluated and how that is not very significant in localizing a pathology. Gait we have not discussed, which we will discuss with cerebellum. And also I deliberately did not discuss a few parts which will be discussed on the next day. So our aim will be with this very basic idea of the physiological mechanisms of regulation of muscle movement, tone, posture, of coordination of movement and sensation. In the next day, we will discuss how can we localize the pinpointed area of damage in the nervous system when the clinical features are presented to us. So our next discussion on the next day will be localizing signs in neurology. And that is a very foundation of not only understanding your basic sciences, but also evaluating a case of hemiplegia and paraplegia. So I think we can end the session today after the end notes given by the organizers. So Devashish and Garima, it's over to you now.
Sure, sir. So thank you so much, sir, for making such a difficult topic easily understandable. I'm sure most of our doubts are cleared by now. If any one of you still have any doubts or any questions, they are most welcome. Send in your questions to our WhatsApp group and we'll redirect them to sir. The notes for today's class and the link for today's video will be uploaded soon and will be posted in the groups very soon. So stay tuned. You can always go back on our YouTube channel for the previous masterclass that was on ECG. If you're happy with the work we are doing, please show us some love and appreciation by liking our videos and subscribing to our channel. Also, follow our Facebook page and Instagram handles for regular updates. DFCs right now, I'll just share my screen. Uh, so DFC is celebrating the Pride Month. So please go and have a look on our articles and posters on Instagram and Facebook. Also, there's a small thank you note for all the donors for Amphan Relief Drive. I'm glad to let you all know that we were able to raise an amount of 50,000 for this drive. I'll share the screen once again. Yeah, so we were able to raise an amount of 50,000 for this drive, and also our relief has reached out to the locals of Sundarbans, one of the worst affected areas by Amphan. So thank you everyone. We'll all meet again on Monday, that is 8th June at 2 p.m. See you soon, and thank you so much, sir. Hope you all have a nice day.